Right. Morning, and I'd like to start by thanking the Turkish Medical Association for having invited me to participate in this meeting, which is organized by jointly with the WMA. I want to start with a small personal experience. I'm a Ugandan, so I've experienced the war in so many ways, and unrest and civil conflict in so many ways. I'll start off with a small experience I had while a medical student. A friend of mine, or a friend of ours, was doing her degree in agriculture, and we were in our hall of the University Hall of Residence, in the same hall. And during the Idi Amin time, that's when I joined the university to do my medical training. And at that time, everything wasn't working. And she entered, there was a part of the lift on the 13th floor where the lift would open up and there was nothing. So the Idi Amin, around the time near the end of his rule, he declared a curfew, and the lights had to be off at about 7 o'clock. So we're sitting downstairs, and she says, I'm going up to have a shower. So she goes up the lift, she gets in the lift, she goes up, she has her shower, and then she forgets that on her floor 13, that the lift sometimes opened without, the lift being there. So she falls down all the way from the 13th floor and lands actually right down in the basement. We hear her screaming, so we come running. And unfortunately, we're not allowed out of the hall residence because of the curfew. So we sat there listening to her groaning until she stopped groaning, because we couldn't move out to go and get help. And she died in that lift at the basement. And we listened to her as young students, listening to somebody who we knew very well die because we were not allowed to move out of the hall of residence because of the unrest that was going on. So that was an experience which I've always, many times I remember that. But it's also something that I keep remembering is that in 1982, graduating as a doctor, we came out of medical school, about 100 of us, and about 70% of us left the country. And this was not only about the war, but also about the economy as well. So sometimes you can't tell the difference between economic migrants and war migrants. Many times it's the same group of people. We need to keep that in mind. But I come across the issue of migrants again, because in 1997, I was approached by an organization called Transcultural Psychosocial Organization. It's a Dutch-funded organization, and it asked me to help them develop mental health services in the northwest part of the country, where we had Sudanese refugees, but also had internally displaced persons. So again, that's another group of people that many times you have both refugees and internally displaced people in the same country. And I still remember that experience from 1997 to 2001, of that work that I did with TPO. Finally, I come across, these days I'm part of an organization called the African Center for Treatment of Tortured Victims, SCTV. It's done a lot of work with ICRC, not ICRC, with the International Council on Rehabilitation of Tortured Victims. I hope I've got that right. But we've been doing a lot of work in terms of training, but also providing services to refugees who come from DRC, refugees from Rwanda, Burundi, Somalia, Eritrea. And that's the sort of work that I do these days. But the Uganda Medical Association, as president earlier on in the early 2000s, the first time I really came to really realize that migration, refugees, the whole issue of war is something that I need to get involved in, was when the World Medical Association asked Uganda to be a center, one of the sites for testing the Istanbul Protocol. Now, I haven't heard the Istanbul Protocol mentioned. Back home in my country, it's mentioned so much. I haven't heard it mentioned in Istanbul. But Istanbul Protocol is something that we've been involved in. We're involved in piloting it as Uganda Medical Association, working alongside a number of other organizations. And it is a tool which we've found among Africans works very well in terms of assessment, documentation, but also in trying to identify what needs to be done for people who are in that sort of situation. So the Istanbul Protocol is another document that I think is something that we need to bring up. Now, I'll go, in my 20 minutes, I'll go very quickly through my slides, but I'll also have something that I'll add on. First of all, that Africa. Many people don't know that Africa has 11% of the world's population. So 11% of the people in this world are on the African continent. And yet we do know that in Europe, you have about 6 or 7 million African migrants that are in Europe. So a lot of our people are out there, but we still have a lot of people on the continent itself. More than 50% of people living on that continent live on less than $1 a day. So poverty is a big issue there. And of course, disease is a big one. High morbidities, mortalities. Almost 50% of the world's women who die from childbirth-related problems are on the African continent. When you think about HIV/AIDS, 67% of the people who have HIV/AIDS in this world are on the African continent. If you think about children dying before the age of 1 year, about 40% of the children in the world who die before the age of 1 year are on the African continent. So disease, poverty is a big issue there. Conflict. I always say that on the African continent, approximately 3 or 4 countries are just coming out of conflict, and another 3 or 4 are ongoing, are in conflict, and another 3 or 4 are just about to go in conflict. So we always have about 7 or 8 countries where there's some sort of conflict that is going on both internally and occasionally between countries. So conflict is a big one. And I want to just say very quickly that historically, I think we were probably better organized than we are now before people came to help us get ourselves organized. I think we were probably more organized, and there was an African democracy that was at work. And 1900, we know we have the scramble for Africa, and then we begin to draw up all those borders. And a lot of these borders are totally wrong. For example, I'm Ugandan, but a bigger part of my tribe is in Kenya. You know, we have the same cultures with that group, the bigger part in Kenya. So a lot of those boundaries should not have been there in the first place. Then, of course, we have the whole issue of divide and rule, you know, that came in. And, of course, struggles, independence. We had leaders that were, at that time, revolutionary, and they thought about justice and fairness. But these days, things have changed, and we are getting a crop of leaders who, nothing to do with, you know, totally undemocratic, corruption, and definitely poverty has increased, and the civil conflict has increased. Now, the drivers for migration: wars, civil unrest, economic reasons, but there's also the environmental factors as well. Climate change has always been a problem that has led to people moving. Well, people move ordinarily. Migration in Africa has always been there, and it's part of everyday life. It's not something that because the boundaries were not known. Now, it's very important for us to look at the health status before migration. And again, I think it was said yesterday that migrants and African migrants too are not homogeneous. They all have different cultures, they have different traditional practices, political systems that they come from are different, and the causes for migration are different. And we must remember that migration is not only south to north, but there's south to south migration, and of course the internally displaced people. So the health status before migration is very, very important. And a lot of the people who migrate, Africans migrating, are young people. And therefore the health literacy of that population, of the African migrants, is very, very important. Where they come from before they migrate. A lot of Africans on the continent do not know, have no idea or have their own ideas about, which are often not evidence-based, on the causes of illness and what will heal those illnesses. So it's very, very important that we do look at the health literacy of the group of people that we're dealing with. And most of these people, as I said, are young and ambitious people. They don't see themselves as needing health, and unless there's a crisis. Now, if there was no nationally organized health system in their country of origin, they are unlikely to have an idea of a health system in Europe, other than going to a hospital during a health crisis. Then we look at health during migration. And this depends upon, we do know that people's health can often deteriorate during lengthy migration. For example, people who move from Somalia, Sudan, or West Africa on foot to North Africa, and then they cross the Mediterranean Sea to get to Europe. They will not be eating, they don't sleep, they don't attend to their personal hygiene, as well as they could for lack of control of their circumstances. And the people smugglers are of a known quantity. There could be violence inflicted on them, on these people, on their way, and they could acquire infectious diseases such as TB, tuberculosis, and sexually transmitted diseases. But they also develop common mental health problems like depression and anxiety, and some will even experience, many of them experience trauma, and so they may, by the time they get to where they're going, PTSD is a common finding. Oh dear, is this working for me? On arrival to Europe, these people's priorities are about getting their legal status. They want to become, they get the documentation done, employment, housing, and understanding the country that they find themselves in. And unless they have an acute condition that cannot be ignored, for which they would go to the nearest hospital, accident and emergency department, they will not understand the primary health care system, and they will not seek to register with the primary care service, especially men. Women tend to understand the healthcare system much sooner, and in case they require, especially if they require family planning support or have reproductive health issues. Now, if they have young families, women are again more likely to plug into the local healthcare system. Now, so thinking about Maslow's hierarchy of needs, as they say, people on arrival will, as a priority, try to meet their psychological needs. So there's the food, there's the water, there's warmth, shelter, clothing. And then they'll consider their safety, and then look at personal security, financial security, and last and the health and well-being. The European Union refers to health as a human right in many communications, policies, agreements, and defending its universality. Now, the specific health needs of migrants who originate from outside the EU have been acknowledged, yet the right to health, if migrants is currently not ensured throughout the EU. And there is a discrepancy between a proclaimed rights-based approach to health and actual obstacles to African migrants' attainment of good health. Thus, any policy making in Europe should strongly encourage its member states to ensure equal access to health care for migrants as well as for their citizens. And it is often challenging for people new to Europe to understand how this health system works. And primary health care is not the same across the countries, we've already heard. And unless Europe takes responsibility to inform people of how these systems work, whether they need to pay for health care up front, whether this health care can be assessed by those who are not documented African migrants. Remember, we have the irregular or illegal migrants, and those who are legal, and those who are documented and those who are not will continue to fall through the net. Now, we have the common health conditions that we need to look at. We have the chronic diseases that our African migrants will tend to suffer like everybody else. Long-term conditions such as diabetes. We have sickle cell anemia, which is tends to be an African problem, glaucoma, high blood pressure, etc. And if left untreated, they are expensive. So whether you're dealing with economic migrants or so-called economic migrants or war migrants, the system still bears the brunt, and it is expensive if you don't have a system don't have a system in place. So the sooner these are identified, the better. Infectious diseases, very, very important to encourage people to seek healthcare services, to be screened and treated. And we do know that they have an impact on public health. And confidential treatment should be a matter of urgency. Mental health, we know that many people have suffered, will have suffered a great loss before they leave their countries of origin, as well as during that journey. And the loss can spread from death of a family, friends, loss of economic resources, money and land, loss of health status, and a feeling of isolation and despondency. Because of these stresses, many of these refugees and asylum seekers suffer common mental health problems, and PTSD, depression, anxiety, and some suffer psychosis as well. Again, here we need to do the assessment that's required, and we need to match these mental health workers with the knowledge and empathy of people's conditions. Now, what are the barriers to accessing healthcare for African migrants when they get to Europe, for example? You have those that are due to the language, the religion, the culture, like any other migrants. The health literacy, very, very important, because that's a big one in Africa. And of course, because African migrants will not travel with their medical history files, that causes a complication. As I said, they're not a homogeneous group, and therefore there are differences in language, differences in economic, social, and educational issues, and between the groups. And many Africans, what they understand as dangerous to their health may be different. For example, many Africans have had malaria. I've had malaria so many times in my life that I might not consider it life-threatening, and yet somebody else would consider it life-threatening. There's also a different cultural understanding around issues of mental illness, depression, anxiety, and psychosis. We do know that as Africans, we have our own beliefs as far as the cause of illnesses, and especially mental illness is concerned, and what should be used to treat these illnesses. Now, there might be, when they arrive in Europe, total ignorance of treatment of these mental health conditions. And so even if every undocumented African migrant was registered with healthcare, given screening and good diagnosis, it will still take time for European health systems and the African migrants to understand each other. As part of my course as a psychiatrist, I did 3 months. In the curriculum, we had 3 months of religion, tradition, and culture. And you sat alongside a traditional healer with all his feathers and everything, and tried to understand some of the stuff that he did. I remember asking one of the people that were supposed to be trainers, and I said, but what about all these feathers and all these things that you have, and the house you have to go through, bend down as you're going into the little place where you get the treatment from? And he said, but you wear the white coats and the stethoscopes and everything. It's just to add a bit of, mystify a little bit. It makes makes you more believable. So we did that as part of our training, and it did a lot on changing our attitude towards African medicine. So it is important to be able to understand each other, the African migrant and the person delivering the service here in Europe. And women from different cultures respond differently to maternal and reproductive health messages, anything to do with child health and anything that needs decision making. And of course, our messages need to be culturally sensitive, and they need to be, they need to be able to get the message across clearly. Now, when it comes to children, amongst the many migrants, African migrants, a significant number of these are unaccompanied minors under the age of 18. They will not only have suffered trauma from that journey, but they've been separated from their families, and they've been vulnerable to people traffickers, being sucked into petty crime and the sex trade, and prostitution by gang masters who purport to offer them protection. They have no knowledge of what it is, what a safe adult is, or a safe adult to turn to. Some will not have completed their childhood inoculations. It's very important to take note of that. And therefore, it's important that the European Union should establish health and local authority networks that ensure that the child that this Children Act legislation applies to these children, and that safeguarding processes are put in place immediately the age of the child is established. Now, the administrative barriers, I'll put those down, about the law policy, which include limitations to access and type of health care. And I think what needs to happen here, and it's been said before, that there are these barriers which focus on the migrants' fear of deportation, stigma, and the lack of capital. The medical profession, as we need to advocate for policy change to increase access to health care for these especially undocumented immigrants. I need to move on. I wanted to just quickly, it's not on us, it might not be, okay, just very quickly say that I come from a country where the Zika forest is. I was telling my friend Vivian that the Zika forest is in Uganda, actually. In case you didn't know, not that I have the Zika virus, but it is in Uganda. And I just added a few slides just to sort of get an idea of the Zika virus and her stepsisters, yellow fever and dengue. And just to sort of say, sorry. The fairy godmother in Zika forest, it's near Entebbe Airport, and there's a signpost that says Zika forest. And the fairy godmother near the Entebbe Airport says to Zika virus that you too shall go abroad, because everybody else has gone abroad. You too shall go abroad. So the effect of globalization. And suddenly, the Zika virus has significant impact on the international stage. You know, there you are, traveled all over the world, and it came from Uganda, from the Zika forest, where it wasn't being recognized at all as anything that. So we do need to do a lot. It's no longer, we know that it can be transmitted. It was transmitted by mosquitoes in the Zika forest, but now it's being transmitted by human contact and possibly other vectors. And now we're talking about microcephaly and the Guillain-Barré syndrome, and yet we don't have these things back home in the Zika forest in Uganda. So, and the cautions have been given to everybody except, of course, to Ugandans who continue to live where the Zika forest is. So the effect of globalization, while we consider the health of migrating Africans across the countries and continents, we should also consider the migration of diseases across countries. And we know that WHO has declared it an emergency, but we need to do more research, of course, to make sure that we get it right. I wanted to end, it might be on a slide, might not be, on what should physicians do for African migrants. And I think the most important thing is advocacy for quality health services, but also back home, at our home situation, I think we as physicians need to do more work in terms of advocacy, advocating for peace. And we as Uganda Medical Association have been working with others throughout from the 90s, linking up with other organizations to advocate for services and taking part in the advocating for peace. We do now have an anti-torture law, and that again came out through a lot of advocacy. Because it's one thing running to a country, but running to a country which doesn't recognize torture as an issue is also not a good thing. Now, again, awareness is important about the health effects, and as physicians, that's something we should do. But the training is very, very important, and we continue in Uganda to train. Kenya is doing the same thing. Tanzania is doing the same thing on the use of the Istanbul Protocol for assessment and documentation, but also to identify what the health issues are. And it's a very good tool. I think you can, any of us as groups or associations can modify it. And we have tried as Uganda Medical Association working with another organization. As I said, the other organization, ACTV, we've modified it so that it suits the training. And we've been doing training of physicians, lawyers, and human rights on the use of this Istanbul Protocol. Of course, we've got to strengthen the training of human rights and ethics, very weak on the in Africa, physicians, in the curriculum, it's still weak. And of course, the training in mental health. We still need to do a lot of research And I think we need to do a lot of research on African migrants. What are their needs, the specific needs, in terms of services, but also information, etc. And of course, we need to put in a reporting system. I was listening yesterday when Sam Michael was talking about numbers, and I was thinking, most of African countries, the numbers, it's getting the statistics is very, very difficult. This morning I was sharing with the fact that we had a census last year, and I don't know yet anyone who was counted in that census, the national census in Uganda last year. I've been asking my friends, did anybody come to your house? Nobody came. So I wasn't counted, but there's a census was done, So you can see that getting the figures is a bit of a problem. And I think we, as organized physicians, can still do, that's something that we can still do on the African continent, but also in Europe where they go. I want to end up by saying that it's very, very important to know that there's as to recognize that this migration is not only south to north, but there's south to south migration. And I think as we do whatever intervention we do put in place, we need to make sure that we do address both the south-south migration as well as the south-north migration. Thank you very much.
Thank you very much, Margaret. Questions, comments, please. Okay. Can we get a mic?
Thank you, Gunta Anzane, Latvia. We all know from clinical practice that in Europe we have a lot of patients with so-called primary gain or secondary gain of illness. And it means that these are patients who unconsciously are not willing to be healthy due to different reasons. The illness as something that supports their self-esteem, or the reason who gives them more money or some good things like different financial support and so on. My question to you, what is your experience and what do you think in these patients from Africa? Are they without this primary and secondary gain of illness, and are they willingly indeed to collaborate with the doctors and to get again healthy, or this panic and anxiety is making them willing to be, let's say so, ill for getting some good news, some good things in the world? Thank you.
Mm-hmm. I hope I have understood the question. You're talking about an African migrant?
First of all, I speak about European patients. We need, from the clinical practice, here is some things as primary gain and secondary gain of illness. Mm-hmm. And my question is, do you see that something like that can be observed in African patients too?
Oh, yes, of course. Of course, African patients are like European patients. We're not very different. I think the differences is in the way we understand the cause, the way what we see as treatment for our illnesses, as cause and treatment for the illnesses. But definitely primary gain, secondary gain, yes. African patients are like European patients. They're not different. Yeah.
Please.
But I think it's very, very important to understand each other. And I think what I found when I was working in northwest Uganda is that just because I'm an African, I can't just work with any African, refugees, for example. You've got to understand, you've got to take time to understand the culture and to understand what they see as the cause of illness. And sometimes we do say there must be gain here, secondary gain or primary gain, when the people want to remain ill. But it's because of the way we understand them, or the way we don't understand them. We don't appreciate the way they perceive the causes of illness and what will treat those illnesses. So we do need to make sure that people who are taking care of these people have the necessary training and orientation on how these people are likely to view. And don't think just because you understand the Nigerians, therefore you can work among the Kenyans, you can work among the Ugandans. They're all very different people. We have about 30 tribes in Uganda, so even I don't understand some of the languages in Uganda. So, you know, so we are not a homogeneous group as Africans.
Margaret, but maybe I can rephrase a little bit this question and to get from you, how is important for physicians to be aware of the background of this migrant patient? How is it important to understand his culture, his preferences?
I think there is a transcultural aspect to diagnosis and treatment of patients, and even rehabilitation. And I think it's very, very important to understand, to appreciate it. That's why I said that as part of my course, we had 3 months of training just to try and get us to understand the Ugandan culture. So you can imagine trying to understand the culture. It is important and very, very important. The other thing about it is that as we develop our systems, whether our healthcare systems, it's very, very important that we build on the existing support systems that people have. Just putting new systems on them, usually it does cause a bit of problems in accessing the services.
Okay, thank you very much.
So it is very important to understand them, yes.
We go on.
Can I just say that most times we take it for granted that if we're working with a group of African migrants, therefore you get Africans to work with them. And sometimes you take it, and I think that is, and many times the same Africans have also had the same issues, and they need help too. So we've got to make sure that they themselves get the service, get help, in order to be able to help others.
Okay, Margaret will participate in the panel discussion later on, so the last question, please, at this stage. Okay,
I come from Sweden, and I think what holds our country together is trust. Trust that the money, tax money we pay eventually lands approximately where it should be. And trust holds a country together. Is there trust in Africa, in authorities, in national states, or do people expect madness at that level? Because if someone comes to a country like ours and has never experienced trust, they don't understand what we're talking about. And that, of course, is a major problem. Can you say something about that? Is there trust in governments in Africa?
I think the misperception is that they've never experienced trust. I think that's a misperception already. I think Africans do experience trust. I think Africans have their traditional, if they had been left with their traditional systems, they would have done better than they've done now in many of these countries. Remember that Africa has 52 countries. So when you talk about Africa, it's not one country. So Africa and Sweden cannot be compared, Sweden and Africa, because Africa has 52 countries. It's 52 Swedens, different, it's more than Europe. So I think a lot of what's happening, because you said two different things there, I think a lot of what's happening in Africa is there's a wave of neo-colonialism, if I can call that, you'd be allowed to use that term, in that I think a lot of what's going wrong comes again from this part of the world. It's either ignored, you know, and people turn around and say, well, let the governments do what they want, you know, and I think we can all be, you know, we are all responsible for what's going on in Africa. I think we can't stand aside and say that Africans are the only ones responsible. I think a lot of the world is responsible for what's going on in Africa. But when you talk about trust, it takes time to build trust between a patient and a health provider. And as I said, that if people believe, if somebody believes that their traditional, that their illness is not going, it needs a traditional healer. You're not a traditional healer. You're not dressed like one. You don't speak like one. So why should I trust you? Why should I trust you? The good thing is that a lot of the migrants do move with their traditional healers. And it's just that we need to be able to identify where they are and work with those traditional healers instead of trying to introduce new systems of treatment. And maybe introduce them, but through the traditional systems, support systems that the African migrants come with. African migrants move with their traditional healers. So there are traditional healers in Sweden. You've got to find where they are and work with them, or become one yourself.